All right, let's jump right into this explainer. We are tackling an advanced clinical simulation matrix today, and we're going to be covering intricate endocarditis pathogenesis, embolic trajectories, and some absolute management contraindications. If you are targeting a perfect 270-plus score on the boards, this is exactly the level of integrative simulation you need to master. So, let's get to work. We're going to establish our baseline framework right here with the virulence division. We really need to contrast two completely distinct clinical pathways. On one side, you've got acute infective endocarditis. This is driven by the highly virulent Staphylococcus aureus, and it strictly targets healthy, native valves. It hits hard, resulting in rapid, severe valvular destruction and profound systemic toxicity. On the flip side, we have subacute infective endocarditis, which involves the viridans group Streptococci. Now, these organisms possess low virulence. What does that mean for us? It means they establish an insidious, sneaky colonization strictly on previously damaged or abnormal valves. They need that pre-existing defect to take hold. Okay, so how do we properly apply the modified Duke criteria? The absolute key here, what you really need to lock in, is that echocardiographic evidence of an oscillating intracardiac mass or a new valvular regurgitation must definitively pair with continuous bacteremia to meet the major criteria. You cannot have one without the other to secure the major diagnosis. It's this exact combination of microbiology and structural pathology that seals the deal.
Now, when we're differentiating the physical stigmata of endocarditis, mechanism is absolutely everything. This is a classic trap. You're looking at Janway lesions on the palm and a splinter hemorrhage on the nail bed. The trap is confusing the pathophysiology. You have to remember, both of these are purely vascular phenomena. They are the direct result of microemboli. That makes them entirely distinct from immunologic markers like your Osler nodes or Roth spots, which are driven by immune complex depositions. Don't mix those two mechanisms up.
Here is our first clinical variance box. Let's examine how a singular pivot in the patient's history completely alters the pathogen and the valvular trajectory. Think about an IV drug user. They are introducing bacteria directly into the venous system, right? That makes Staphylococcus aureus the primary driver, predominantly attacking the right-sided tricuspid valve. Now, contrast that with a patient who has a congenital defect, like mitral valve prolapse. This pre-existing endothelial damage on the left side of the heart acts like an absolute magnet for viridans streptococci following a transient bacteremia, say, from a routine dental procedure.
Right, let's move into our first integrated assessment. This demands that you synthesize the clinical timeline, the pre-existing endothelial damage, and the microbiological data all at once. We have a 32-year-old female with a history of mitral valve prolapse. She presents with a 3-week history of low-grade fever, fatigue, and new Roth spots. Her blood cultures grow gram-positive, catalase-negative cocci. Which of the following is the most likely pathogen and its primary mechanism of colonization?
So, the crucial step here is surgically eliminating the distractors. Option A, S. aureus, is highly virulent and invades healthy tissue. It just doesn't fit our patient's slow, subacute 3-week timeline. Option C, S. epidermidis, that relies heavily on prosthetic material biofilms, which she doesn't have. Option D, Enterococcus, typically follows GI or GU translocation. And option E, S. bovis, is famously linked to colonic malignancy seeding, pretty unlikely in a 32-year-old. This heavily, definitively isolates option B, viridans streptococci. The insidious 3-week timeline, combined with her abnormal native valve, points directly to viridans adhering to her pre-existing damaged endothelium.
Moving right along into Module 2, we're shifting our focus to the systemic vascular complications of left-sided vegetative lesions.
Left-sided vegetations frequently fragment, and when they do, they essentially send septic missiles directly into the systemic circulation. These emboli have a classic trajectory. They typically lodge right in the middle cerebral artery, or MCA distribution. Embolic occlusion of the MCA produces very specific acute focal neurological deficits. The mechanics you're looking for are heavily weighted toward contralateral paresis and sensory loss, primarily in the face and the arm. You'll also frequently spot a gaze preference toward the side of the lesion and contralateral homonymous hemianopsia. Crucially, pay attention to the hemisphere. If the dominant hemisphere is hit, expect expressive or receptive aphasia. But if the non-dominant hemisphere is involved, you're going to see profound spatial neglect.
Listen up, because this is an absolute management restriction and a massive high-yield trap for the boards. In cases of suspected or confirmed infective endocarditis presenting with acute ischemic stroke, administering IV alteplase, TPA, and systemic anticoagulation like heparin are absolutely contraindicated. Why? Because the mycotic necrosis of the arterial wall creates an unacceptably high risk of catastrophic hemorrhagic transformation. Do not push those drugs. Let's look at another clinical variance box to really hammer this home. Standard stroke protocols dictate that if the last known well is under 4.5 hours and blood pressure is controlled, you administer TPA. Simple, right? But the presence of endocarditis completely reverses this mandate. Full stop. If the stroke is endocarditis associated, you must withhold TPA. Your strict reliance shifts entirely to obtaining blood cultures and immediately initiating empiric antibiotics. Let's tackle our Module 2 assessment. This presents a classic high-acuity dilemma where standard neurological protocols clash head-on with infectious disease realities. A 28-year-old male IV drug user with a newly diagnosed mitral murmur developed severe right-sided hemiparesis and expressive aphasia 2 hours ago. His CT head is negative for hemorrhage, and BP is well controlled at 140/90. What is the most critical next step in management? Let's break down these 5 options. Option A, administering IV alteplase, and Option B, initiating therapeutic IV heparin. These are lethal distractors. They are absolutely contraindicated due to the hemorrhagic risk of an infected vascular wall. You will kill the patient. Option D, emergent surgical valve replacement, is way too premature before medical stabilization and source control. Option E, oral aspirin and clopidogrel, is completely insufficient for an embolic source of this magnitude. Therefore, Option C is the only correct path. You have to bypass thrombolytics entirely and strictly target the infectious root cause by obtaining blood cultures and starting empiric vancomycin and ceftriaxone.
Okay, we move strictly into Module 3 now, where we analyze the progressive degradation of cerebral vasculature.
Let's carefully define what we're looking at here. A mycotic or infectious aneurysm represents a localized transmural inflammation. Septic emboli actually seed the vasa vasorum of the cerebral vessels. From there, they actively digest the arterial wall from the outside in, which drives severe structural degradation and subsequent aneurysmal dilation. It's literally eating the blood vessel from the outside.
This variance box forces you to contrast 2 very distinct vascular catastrophes. A septic embolus presents as a sudden electrical failure. It's an abrupt onset of isolated focal deficits that immediately localize to a specific vascular territory, exactly like we saw with the MCA. Conversely, a mycotic aneurysm presents like a progressive pressure cooker. It manifests as a progressive, unrelenting headache, potentially with new focal cranial nerve palsies, and it steadily escalates until it reaches catastrophic rupture. And that brings us to a strict diagnostic mandate. If your endocarditis patient develops severe, unremitting headaches, that is a glaring red flag. You cannot ignore it. You must execute an immediate CT angiography of the head. The absolute clinical goal here is to map the aneurysm for surgical or endovascular clipping before it bursts. Our final assessment drops you right into the aftermath of a missed diagnostic window. It requires you to identify the precise mechanism of a catastrophic complication. A 45-year-old male who was actually responding well to IV ceftriaxone for S. viridans endocarditis suddenly complains of an excruciating thunderclap headache and exhibits nuchal rigidity. A stat non-contrast CT shows hyperdensity in the basilar cisterns. What is the pathophysiologic mechanism of this patient's acute decline?
Systematic elimination of the distractors is key here. The clinical picture of a thunderclap headache and basilar hyperdensity on CT confirms a subarachnoid hemorrhage. Option A, hemorrhagic transformation, usually follows a localized ischemic infarct. It doesn't typically present with basilar hyperdensity. Option B, immune complex deposition, causes things like glomerulonephritis, not a massive subarachnoid hemorrhage. Option C, septic embolization, causes sudden focal weakness, not a thunderclap headache. Option E, rapid vegetative growth, leads to acute heart failure, not intracranial hemorrhage. This definitively isolates Option D. The exact consequence of an expanding, undiagnosed mycotic aneurysm is transmural inflammation and the subsequent catastrophic rupture of the cerebral vessel wall. That concludes this highly integrated clinical simulation explainer. If you can anticipate these specific traps and master these exact structural pathways, you are well on your way to dominating your exams. Keep grinding.